This Cesarean scar pouch, or niche as some authors have described, can be filled with fluid, and the fluid may be there during the routine transvaginal scanning. If fluid fills this area during sonohysterography, it can allow one to actually measure the size of the defect, and people have found that this correlates well on hysteroscopy. The scar can therefore act as a reservoir for blood and cause abnormal bleeding in patients. What percentage of women with a cesarean section will actually have a demonstrable niche is unknown. But if the patients give this history, it's important to look for the possibility of this niche. This patient happened to have an immediate post-section CT after the cesarean section, which occurred in 2005, and the incision was actually off to the side at about 9 o'clock in this uterus. She returned in 2006 and was having a CT scan for other reasons, and in between she had had an intrauterine contraceptive device placed. If you notice, here's the IUD, and it's exactly at about the location of the site of the prior cesarean section incision. It should have been in the endometrial cavity, which is this place right over here. And in the sagittal reformat, you can see it's in the lower uterus, but none of the IUD was located in the upper uterus. This is an example of an IUD that is malpositioned related to the cesarean section scar. The patient went on to have a transvaginal and a transabdominal sonogram, and again demonstrates most of the IUD was in the lower uterus, and a portion of one of the side portions of it was stuck in the scar from the prior cesarean section. This is the transvaginal, and this is the transabdominal of the same patient. Clearly important for the patient, who is not fully protected given the location of the IUD. Here's another patient with a malpositioned IUD at the cesarean section scar. Again, most of the IUD in the cervix, and here are the side portions of it at the level of the cesarean section scar. This patient did end up with the complication related to this because when we scanned her, she was pregnant. And here's the gestational sac higher up in the uterus. She was not protected by this IUD. This patient is another one who had had a CT scan several days after a cesarean section for unexplained fever. This is the coronal reformat showing the incision. This is the bladder. This is the axial image, and there was a fairly normal looking site of the incision. There was no complication here. Several months later, the patient returns for imaging. She's now pregnant and she's having some bleeding. This is the transvaginal view of her uterus. There is a gestational sac, and it's located right here. So it is in the uterus, but if you look very carefully, it's not exactly where you would expect it in the uterus. This is the endometrium, and this is the gestational sac. You can see the yolk sac. This is a gestation that is implanted in the cesarean section scar. It is a cesarean section scar ectopic. The patient was treated with systemic methotrexate and 5 days later had a follow-up, which unfortunately showed that the pregnancy was growing appropriately. There was now not only a yolk sac, but now we could visualize an embryo that had cardiac activity. And again, you can see the measurement being made here of the thickness of the myometrium that overlies this gestational sac. And from having seen the other images I showed, this is clearly at the location of the cesarean section. So she was given a second dose of methotrexate. Unfortunately, 2 days after that, the pregnancy was still alive and surgery was required. Another patient with a history of only one prior cesarean section came in. She was pregnant and having bleeding. There was a gestational sac low in the uterus and it was empty and interpreted as an abortion in progress. She returned, however, 1 month later with bleeding, and this is the transabdominal view of her uterus. The endometrium is normal, there's no gestational sac, but there's sort of a mixed complex low and high echogenicity collection exactly at the location of this gestational sac on the prior study. When we put color Doppler on, it was exuberantly, beautifully vascular in this region. So what we're dealing with here is a patient who had a cesarean scar implantation, but most of the sac passed in a spontaneous abortion. Unfortunately, the retained products of conception are at the site of the cesarean section scar. This type of ectopic pregnancy is rare but increasing in incidence as the number of cesarean sections increases. It is defined as a gestation completely surrounded by myometrium but separate from the endometrium and separate from the fallopian tube. Several reports show that this can occur within months of the delivery, and therefore incomplete healing of the scar may contribute to it. The ultrasound findings are those of an empty uterine cavity, an empty cervical canal, and a gestational sac in the lower uterus. The differential diagnosis, as you can see, includes a spontaneous abortion in progress and a cervical ectopic pregnancy. The problem is that rupture can occur, and often the diagnosis is delayed, in part due to lack of education about the possibility of this, but also the overlap with the other diagnoses. Despite an increased incidence, it is still such a rare ectopic pregnancy that there are no specific guidelines for treatment. Medical therapy can be tried, but often a surgical therapy for removal is required. This patient was 30 weeks pregnant and started to have gross hematuria. And this is ultrasound imaging of the lower uterus and bladder. This case was graciously lent to me by Dr. Sandra Allison of Georgetown University. If you look at the posterior wall of the bladder, you can see these cystic areas, which with color Dopplers show that they are vessels and exuberant flow. On transverse imaging through here, there's echogenic material and cystic areas with blood flow. This is an example of a placenta percreta, or placental invasion of the bladder, and it is related to the prior cesarean section. So these are all in the realm of placenta accreta. An accreta is when the villi are in direct contact with the myometrium without any intervening decidua. Increta is a deeper myometrial invasion, and percreta is invasion to the serosa and occasionally to the bladder and bowel. The major risk factor nowadays is prior cesarean section, but obviously instrumentation can also predispose to this. It can result in life-threatening hemorrhage at delivery or even before, because the placenta will not separate from the myometrium. Modalities that can be used to make this diagnosis include ultrasound and MR. It's usually done without gadolinium when the patient is pregnant. It's unclear which has better sensitivity and specificity because it is an unusual and, I must say, a difficult diagnosis to make. If the placenta is anterior, ultrasound is better. If the placenta is posterior, MR may be better. The criteria for suspecting placental invasion on ultrasound include loss of the retroplacental hypoechoic myometrial zone, numerous vascular lacunae in the placenta, a disruption of the echogenic boundary, and nodular projections beyond the uterine edge. If you think about it, there are some similarities between placenta accreta, which is myometrial invasion of placenta, and a C-section ectopic, which is an abnormal implantation site of the actual pregnancy. This patient, who had prior cesarean sections, gave a history of increasing pain and a small mass at the cesarean section site. And imaging with a high-frequency transducer at the level of the umbilicus showed a lobulated hypoechoic mass with some flow. You can see the muscles on either side. And this is an example of endometriosis in the cesarean section scar. Another patient with a similar problem, you can see the uterus is pulled up anteriorly. This is the adhesion, and here's the enhancing nodular endometrial implant exactly at the site. This is the sagittal view showing you the adhesion of the uterus to the anterior abdominal wall. Endometrial implants can occur related to the scar and as a spread of the spread during the surgical procedure. Patients often have pain and tenderness that come with the cycle and with their menses. The appearance can be variable, but is typically relatively solid. There may be vasculature as well. There are fibrous tumors that can have a similar appearance, and these will usually enhance with contrast. And this is the last situation to show. This patient had a history of 3 prior cesarean sections, and as you can see, has a defect in the anterior abdominal wall, and this ventral hernia has incarcerated bowel in it at the site of the prior cesarean section. Thank you very much.